Welcome to Life by 1,000 Cuts, a podcast series about skin cancer surgery. I am your host, Associate Professor Tony Dicker, and in each episode we'll share practical insights to support your skin cancer surgical practice. From clinical tips and case studies to journal reviews and interviews with skin cancer colleagues. Today we are looking at a journal article about some fairly novel options for managing keloid scars. So let's get into it. A few years back, Professor Diona Damian from Sydney reminded me about medical daydreaming. It's that process where you flick through a journal and come across articles that are outside your usual area of practice, but make you think about how they might apply to what you do. I've been bad at this in recent years, so I figured that if I force myself to talk about a journal article once a month, then I'll have to start daydreaming again. So I did exactly that. I pulled out this journal. Well, actually I logged into this journal. I don't use paper these days that much, although I do miss it. And just started flicking through, seeing what I could find which might be of interest. And in doing so, happened to come across this particular article, which made me double take. Insulin and Botox for keloids. And I had to double think about that one. It didn't make sense. But I went through and we had a look, and let's have a look at it today. So this is from the Journal of Dermatologic Surgery in June of 2025. And I must admit, I've never really thought of using either insulin or Botox for keloids, but it's out of the Zagazig University hospitals, which are north of Cairo in Egypt. And they had 63 patients in their trial. They had the normal exclusion. So all the patients were older than 16 years of age, none were pregnant or lactating, and sensibly given the nature of one of the agents, none of the patients were actually on insulin or oral hypoglycemics. And there was a 6-month washout. There was no other treatment to the particular lesions 6 months before the trial. They used what's called POSAS, which is Patient Observer Scar Assessment Scale. And of course, this has to be subjective to some degree, but it's certainly quite appropriate. For keloids, it looks at vascularity of them, pigmentation, overall thickness, how stiff or pliable they are, and also the symptoms of keloids in terms and how much relief of symptoms they achieve with the treatments. The injection techniques they used were the same for the different agents, which was good. It was basically the injections were 1 month apart and 4 injections in total. So there's a 4-month trial for each individual patient. This is how they approached it all. Now, the 3 agents they compared, as mentioned in the title, they had insulin for injection into the keloid scar. They had Botox to inject into the scar. And their control, so to speak, was steroids. So corticosteroids is our usual thing we think of injecting into keloid scars, although that made it quite a nice control. Now, of interest, there was no true placebo in terms they didn't try injecting water or saline, or they didn't try not doing any treatments of any sort as a control against the results there. So how did they go? So here's what they showed. As I mentioned, there was 63 patients and they were randomly allocated to either receiving insulin, Botox or intralesional corticosteroids. It was monthly for 4 months, as I mentioned earlier, and subjective measurements that we discussed just before. All 3 groups did show some statistical significant improvement, which is important, and mainly by those measurements. Overall, they had a 66% improvement with insulin, compared to a 25% improvement with Botox, but that was compared to their control being corticosteroids, where they had a 75% improvement. So overall, although statistically not better than the insulin, the best result was actually with our traditional treatment of intralesional corticosteroids. Now, the other thing they mentioned in the article, of course, is what sort of side effects they noted. And for those who were having the intralesional steroids, 13 of the 21 who received steroids were noted to have atrophy and telangiectasia around the scar, which is what we expect to see. And they noted that they didn't see any particular changes like that with either insulin or Botox, so the atrophy and telangiectasia was not a feature of either of those treatments. 8 of the patients who received insulin did have mild hypoglycemia during the treatment, which was quickly and simply reversed with a dose of sugar. So whether it was a sugary drink or even just a sugary food, stopped that problem quite quickly. They also did a follow-up at 3 months for all of these people. There's no particular sudden rebound growth for any of the groups. So they felt they had a potential longer-term effect rather than just being a very short-term effect. But the review was only 3 months. So how do they conclude things from there? Well, they did mention this is probably the first study of using insulin for keloids, and I haven't gone back and done extensive searching for that, so I'm happy to believe that. And it certainly wasn't something I'd ever thought of before. They did mention a number of other studies using Botox in the past as a treatment for keloids and other scarring. And so it was interesting to have this comparison of the effectiveness of Botox versus other treatments. I suppose what I noted was that it wasn't really any improvement to our more traditional treatments, including intralesional steroids. So if we think about what we'd normally do for a keloid scar, obviously discussing with the patient and explaining what a keloid is and how they evolve is a very important part of the treatment. But typically I would start with something topical and simple, and it's usually a silicone sheeting. And the big effect I'm trying to achieve with silicone sheeting is just getting rid of the itch and irritation. So the symptoms of the scar can sometimes be the most worrying thing for patients, where there's not so much the appearance, because a lot of them are actually hidden, but if they feel their keloid scar every day and it's irritating, just relieving that gives some value to the patient. So I normally start with silicone sheets or something equivalent. My next usual go-to would be the injections of steroids. And then the third step after that was considering different methods of excising the scar or partially excising the scar, and combining that with other treatments such as steroid injection or radiotherapy. There's a few different options there. So from this study, I thought, well, I'll include insulin in my list of considerations, but it certainly wasn't my first line therapy I was going to run to. I didn't see an obvious advantage of changing my practice into injecting Botox into keloid scars at this stage. But again, I'm going to keep it in mind as an option if other things have been exhausted. But really that's at a point in the patient's care where I've already referred them. So this is in a primary care setting, that use of silicone sheets and use of injections is a reasonable thing. But if you're having a lot of trouble with managing a keloid scar after those sorts of treatments, I'd certainly be looking at referring and sharing the love, getting multiple opinions about managing of these scars, because they can be a really difficult problem to manage. And so just to have others involved in the care and multiple opinions is usually worthwhile. That's all I wanted to talk about today. I hope you found this episode helpful and perhaps even picked up some suggestions of what you might do or change in your clinical work. A big shout out to HealthCert for all their help with production and distribution of this episode. They do a lot of good things in skin cancer education space, including helping get this podcast out to you. If you're looking for other skin cancer education, then it's worth looking them up. Thanks for listening, and I'll see you next time on Life by 1,000 Cuts.